So, hi everyone. My name is Jessie Keavney, and I'm from Pendergrass, Georgia. I want to thank Cure Parkinson's for inviting me to contribute to the Rallying to Challenge meeting by sharing my personal story relating to my family's research involvement journey. I thought I would take you through the generations and start with some background related to my grandfather, then talk about my dad, and finally my own research participation experience. I think in order to understand where I'm coming from as far as my motivations and my emotional investment in PD research, we have to start at the very beginning. So here are some pictures of my paternal side of the family. On the right is a picture of my grandparents along with my dad and uncle taken in the 1950s. My grandfather Louis and my dad John are pictured on the top left, and the bottom left is a picture of my great-grandmother Estella. In 2013, my grandmother passed away just 1 month shy of her 100th birthday from Alzheimer's. It was at that point that I started to feel a real loss because I really wished that I had asked her more questions before her memory started to fade. I knew my grandfather had Parkinson's, and my dad did too, but she never really talked about it. And my dad was too young when his father died to remember very much. He was only 7 years old, and my uncle was only 11 at the time. So here I am thinking, my grandmother and both of her siblings died from Alzheimer's, and my grandfather and my dad have Parkinson's. And naturally, I start to wonder, what is the risk that I will get a neurodegenerative disease too? But that is where 23andMe came in. I was the first person in my family to take the at-home genetic test back in 2013. And that is when I first learned that I'm a LRRK2 G2019S carrier. It was only after I received my results that my dad was tested. And of course, it was found that he was a carrier as well. I didn't know until after I took the DNA test and started digging into my ancestry that my great-grandmother was full Ashkenazi Jewish. Her family immigrated to Virginia from Germany in the 1800s. She is my only Ashkenazi Jewish great-grandparent, so we're almost certain that she carried the LRRK2 variant that was passed down to my grandfather, my dad, and me. My grandfather was half Ashkenazi Jewish, my dad a quarter, and I'm 1/8 Ashkenazi. My great-grandmother Estella lived until the age of 86, and to our knowledge had no Parkinson's symptoms, at least none that were recognized at the time. Her death certificate lists cerebral thrombosis and gastrointestinal hemorrhage as the cause of death. Since I was only 36 years old in 2013 and I didn't know my ancestry in the beginning, I would not necessarily be a target in outreach programs for recruitment of carriers for research. However, literally within a week of learning my genetic status, I was already inquiring about participating in a research study, and it's been nonstop ever since. So one of my biggest inspirations for research involvement is my family. My grandfather was a very intelligent man. He was an inventor and a research and development lab engineer for General Electric Company. He held 16 US patents. One of them is shown here on the left. And during World War II, he was a member of the National Defense Research Council and worked on a US government group that conceived and developed homing devices for torpedoes launched from submarines. My grandfather's young family and career meant everything to him. However, at only 45 years old, my grandfather was diagnosed with Parkinson's disease in the early 1950s. And to put this into perspective, is shown here with my grandfather's prescription dated 1956. This was before levodopa was even discovered. My grandfather was fairly young at only 50 years old when he made the very difficult decision to undergo 2 brain surgeries called polydectomies. We have to remember that this was 64 years ago, and neurological surgery for Parkinson's was, in my opinion, still largely experimental. For those of you that have had DBS surgery or considering DBS surgery, you know how big of a decision that is. Now imagine that you live in 1957 and the unknowns around that. I consider my grandfather somewhat of a pioneer. One of my most emotional and nostalgic experiences of research participation was when my dad and I traveled to New York to participate in a biomarker study at Columbia, and we walked the very same building that my grandfather was in decades earlier. Afterwards, my dad and I spent some time in his childhood home in Massachusetts. While exploring in the attic, I found some letters addressed to my grandmother from my grandfather's doctors after he passed away, and I'd like to read them to you. They give you some background and insight on how it must have felt to be a young PD patient in the 1950s. The first letter is dated April 8th, 1957, and was written to my grandmother from J. Lawrence Poole, who was the director of neurological surgery at Columbia University and the Neurological Institute of New York. He was a world-renowned neurosurgeon, and one very interesting fact is that J. Lawrence Poole was actually credited as being the first person to perform deep brain stimulation on a PD patient back in 1948. So the letter from Dr. Poole regarding my grandfather reads, "Dear Mrs. Ronaldo, let me say again how deeply saddened I have been over the tragic loss of your very brave and wonderful husband. I came to know him and appreciate him so much that I was more than usually anxious to have all go well. As I wrote Dr. Budwitz, the double operation plus his high blood pressure and associated circulation hazards proved too much. To you, let me extend my very deep and lasting admiration for your extraordinary devotion and exceptional courage through this long ordeal. Your bravery, too, will never be forgotten. Most sincerely, Lawrence Poole." The second letter is also dated April 8th, 1957, and was written to my grandmother from Dr. David Morrison, my grandfather's primary care physician. It reads, "Dear Mrs. Reynoldu, you and the boys are very much in my thoughts today. It is a great sorrow to realize that the best that could be offered was not enough. You know without my telling you how much your husband had come to mean to me. I can only hope that the courage you both displayed will continue to carry you through this hard time. What little anyone can do to help, you know I am anxious to do. Sincerely, David Morrison." Reading both of those letters really hit home the enormity of what my grandparents had went through. Both letters refer to and capture their bravery and courage. My grandfather was a scientist. He knew the risks, and yet he decided to go ahead with it anyway. I think it's fair to say that he must have felt a good deal of desperation as well. The brain surgeries were his best attempt at the time to escape his suffering. For me, my grandfather's experience serves to remind me how far we have come since the 1950s, but also how much we depend on scientific discovery and research participation to keep improving to develop safer and more effective treatments. It inspires me to do my part too. I also found another letter that I'd like to read to you. This letter is dated April 23rd, 1957, and was written to my grandmother from Dr. Poole following my grandfather's brain autopsy. It reads, "Dear Mrs. Ronaldu, thank you so much on behalf of us all for your extremely kind and so thoughtful letter. This was a rare and beautiful tribute, enormously appreciated by us all. I've naturally shown your card to all the doctors and nurses concerned. The examination you so nobly permitted was a vast help to all of us concerned with this vexing problem of treating Parkinson's disease. For your consolation, as I wrote Dr. Budwitz, the main artery to the vital base of the brain is a vestige of its normal size, due to extensive thickening of its walls that had been going on for years as part of his high blood pressure disease. In a short time, this artery, the basilar, would have closed off completely and spelled the end. It was this blood vessel trouble, too, that caused his disease of Parkinson's trouble and precipitated hemorrhage. The two treatments were found to be precisely in the correct and proper location, so that we know we proceeded perfectly all right with each operation. Believe me, we are working hard to try to lick this horrible disease, and I am sure we will gradually continue to learn more and more. With my best regards to you and yours, J. Lawrence Poole." It was pretty profound to read that letter about my grandfather's death so many decades ago. One of the things that stands out to me is that the doctor said something really bold. He said that high blood pressure caused my grandfather's Parkinson's. And of course, we know that Dr. Poole would have had no idea about the LRRK2 mutation back then and the genetic contribution towards the etiology of his condition. And it made me wonder, What do you think we know right now in 2021 that we're perhaps misguided about? We don't know what we don't know, but the only way that we're going to get there is through research. Why is it that a significant portion of people with LRRK2 mutations develop PD, but then again, the majority of people with our variant don't? Was Dr. Poole's statement partially correct? Does cardiovascular disease combined with other genetic factors cause PD in a subset of people? We don't know all the answers yet. But the more and more my dad started learning about LRRK2, the more determined we became to contribute to the growing body of knowledge about it. Before I learned that I was a LRRK2 carrier, my dad never really thought about research studies at all. But once we knew about the genetic connection, it opened up many opportunities for both my dad and I to participate in specific biomarker and observational studies. And for many of the studies, we could support one another by doing them together. My dad and I traveled to California together to participate in studies at the Parkinson's Institute, and we both had lumbar punctures together in Washington, and we participated in the early genetic registry of PPMI, and we also completed several studies in New York. My dad did a GATE study at Emory, and he also participated in the PD generation study and ROPAD as well. My dad really loved to talk to people, and I think his favorite part of his research participation was talking to all of the researchers and coordinators at our visit. However, the last couple of years were really, really difficult. My dad was diagnosed around 2002 at the relatively young age of 52. So this year marks about 19 years since my dad was first diagnosed. After my dad had several bad falls in 2019, my sister quit her job to care for my dad full-time. My mom has several major health issues of her own. So my mom was unable to care for him. I continued to work full-time, but since my parents' house is only 3 doors down from me, I was able to help out on weeknights and weekends. In the last couple of years, it really broke my heart to see firsthand the physical and emotional pain of my dad losing his independence. He could no longer walk, he was incontinent, and he had psychosis and significant cognitive impairment. He became totally dependent on my sister and me for everything. And then came the COVID-19 pandemic, something that will forever be etched in the history books on a global scale. Like so many people in this world, my family was personally impacted by the virus. Our worst nightmare happened last December 2020, when both my dad and I tested positive for COVID-19 after I took my dad to the ER for an unrelated issue. He tested negative upon admission to the hospital, but both of us tested positive about a week later. I had a relatively mild case with only a headache, a stuffy nose, and I completely and suddenly lost all sense of smell and taste. I had no cough, no fever, and no body aches. My dad, on the other hand, he developed a very severe case of pneumonia and other complications, and his blood work showed a full-on cytokine storm. My dad tragically passed away 2 months later on February 3rd, 2021. And we're absolutely heartbroken. And I can't do anything to change what happened. But one of the things that I first asked myself was, how do I turn something so negative into something positive? So the first thing I did was I started donating convalescent plasma. But when the vaccine started to become more available, the blood bank stopped testing donor blood for antibodies, but instead they informed me that they really, really needed my platelets. After I had COVID-19, my platelet levels have been high enough that I'm able to give a triple donation in one sitting. So I figured I might as well help as many cancer patients as I can. And then I again turned to research opportunities by enrolling in 2 COVID-19 research studies. One of them looks at how genetics influences someone's susceptibility to COVID-19 and the severity of the viral infection. The other one is a longitudinal research study over 2 years that looks at immune system's reaction to the virus. And I'm part of a sub-study that is also looking at how people with prior COVID infections react to the vaccine. With LRRK2's association with neuroinflammation and immune system function, it does make me wonder what kind of long-term implications my prior COVID-19 infection may have on my future neurological health. And scientific research is really critical to help unravel those questions. And I'd like to take a moment to talk about brain donation, as it's a sensitive topic that is not discussed very often, but I think it's very, very important. My dad was a registered brain donor, and I am too. We made that decision very early on when we first started participating in research 7 years ago. Unfortunately, arrangements with the first brain bank fell through because my dad just had a lot of complicated medical issues, and the first brain bank decided that they couldn't accept his gift. But we had a backup plan with Columbia University's New York Brain Bank. And words can't fully express how grateful I am to Dr. Alcalay and Brain Bank coordinator Matt Surface for the last minute arrangements. Ultimately, I think it's fitting for my dad to be back in the same place where his father was. So I'm really relieved that it worked out. And Columbia has a really wonderful program where they have movement disorder fellow physicians study the clinical case for each brain donor individually, and they present their hypotheses and predictions about the pathology. Then they have the pathologist give a presentation on the actual results to see how they compare. And the family is invited to attend the case conference, which is really, really meaningful to us. So my best advice is to be prepared and make plans well in advance. Even if you're a registered brain donor, it's still up to the next of kin to make the final decision. So having those discussions with your family is very important. Talk to your neurologist or your movement disorder specialist and inquire about whether or not their facility has a brain bank. Also, the best and most valuable brain donations are those that have clinical and research records during life that then can be compared to the autopsy results. Many research studies like PPMI have brain banks established for actively enrolled participants. In these cases, there's no cost to the family for donating a loved one's brain and receiving a pathology report. Brain donation is literally a once in a lifetime opportunity. It's extremely time sensitive, and you have at most a 24-hour window to make it happen. And it's not the same thing as being designated as an organ donor on your driver's license. That is for live organ donations meant for transplants. Brain donations are different. They are for advancing scientific research. And brain tissue is very precious. One person's brain can potentially provide information for hundreds of studies. And donors are needed from a diverse population and of all ages and stages, so that researchers can better understand the causes and progression of neurodegenerative diseases. It was incredibly comforting to my family to know that even in death, my dad's legacy lives on in research. We were able to honor his last wishes because he really wanted to help others. It also provides some closure to know the final pathology results. LRRK2 related PD in particular is very interesting from a pathological standpoint because it's highly variable, even among the same variants. Some people have pure nigral degeneration with no Lewy bodies at all. Then others have Lewy bodies, but they're limited to the brainstem. Then others, like my dad, have severe diffuse Lewy bodies with additional pathologies detected. We found out that my dad's brain resembled someone with Parkinson's disease dementia, which correlates to his clinical records during life. That's interesting too, since generally LRRK2 related PD is thought to have less instances of dementia than idiopathic PD, and it's thought to be slower progressing than other forms. And for the first 10 years, that was true for my dad. But watching my dad significantly decline and struggle over the last several years certainly has not been easy. And if it's so difficult to watch a family member struggle, many people ask me why I wanted to know my genetic risk of getting the same thing. But for me, I absolutely have no regrets about learning that I'm genetically at risk for PD. I would actually have been disappointed if I didn't know about the mutation until much later in life, because then I would have missed out on a window of opportunity to contribute to scientific knowledge early on. I hear many researchers and doctors say that they don't recommend testing in non-manifesting people because there's nothing to prevent PD. And to be honest, I get a little annoyed by that answer because there is something I can do by participating in research. The mutation had been there all along, all the way since conception. But now that I know that it's there, I can contribute in a really meaningful way. I already knew that I had a higher risk of Parkinson's because of my family history. But with the knowledge that I'm a LRRK2 carrier, I can help in ways that others can't. Research participation brings me a sense of purpose, like I'm part of something much, much bigger. Ultimately, we should remember that everyone is different, and it's up to the individual to decide what they want to know. It sounds very cliche, but for many of us, knowledge itself enables a reassuring feeling of empowerment and control. It's not a foregone conclusion that I will get PD. There's lower penetrance for the LRRK2 G2019S variant, so there's a source of optimism. It gives me an extra push to exercise, to eat better, to limit my exposures to toxins as much as I can, and also to keep my B12 and vitamin D levels high enough, since my numbers have historically been low. And if I don't get PD in my lifetime, it's important for researchers to understand why I didn't, since that could potentially help with prevention strategies for others. And even if you already have PD, I think it's important to know if you have genetic risk variants. The current understanding of the interplay between genetics and environmental factors is continually evolving. Plus, there are many clinical trials that are starting to enroll based on certain genetic variants, so it's important to know if you fall into a certain category or not. Overall, it really feels good to do good. I love the saying, action cures fear, because that really rings true for me. There's several things to know about and to think about before pursuing genetic testing. I'm not as familiar with the laws in other countries, but in the US, we have GINA, which stands for Genetic Information Non-Discrimination Act. It protects against health insurance and employment discrimination for people that are at risk for diseases because of DNA testing or family history. GINA protects non-manifest people that are at risk for something but don't have a diagnosis, whereas the ADA, the Americans with Disabilities Act, protects those with manifested conditions. Genetic information is a protected class, the same as race, religion, gender, age, etc. However, one piece of advice I can give you, though, is to obtain life, disability, and long-term care insurance prior to genetic testing if you can, as these special types of insurance are not protected under GINA. You can always cancel the policy later after genetic testing if you're found not to have a variant and you decide that you don't want to pay the insurance premiums. Particularly in the beginning of the era for genetic testing, many bioethicists thought that people would be overcome by anxiety and depression if they found out that they were genetically at risk for diseases. But the first randomized clinical trial that looked at people's reactions to learning whether or not they carry genetic variants for Alzheimer's found that there were no major negative psychological impacts. And subsequent studies have shown similar results. The majority of people who learn through DNA tests that they are at risk for diseases generally handle the information well. Nevertheless, I strongly believe that a person's autonomy should be respected from an ethics standpoint. You have a right to know, but likewise, you also have a right not to know. Everyone is different, like I've mentioned before, as individuals are not averages. You can speak to a genetic counselor if you're unsure whether or not genetic testing is right for you. As I mentioned previously, I've had really positive experiences from research participation and has helped me cope with the genetic risk. And this next slide represents the many different biomarker or observational studies I've participated in over the past 7 years that included blood, urine, stool, CSF, skin, saliva, breath, smell, PET imaging, functional MRI, cognitive tests, gastrointestinal tests, questionnaires, etc. What a shame that all of my individual results from all of those different biomarker tests from researchers over the years are not consolidated into one research record that is saved in a similar way as my clinical electronic health record. It's such a rich data set, and it's not just brain research. I already mentioned the COVID research, but there's others too. For example, I had preeclampsia with all 3 of my pregnancies, so I've done research in that area. And I was found to have fructose intolerance from a breath test, so I've participated in an interventional trial for that too. I think once you start participating in research, the momentum starts to grow and you become more open to participating in even more studies. There's just so much information there that has been collected over the last several years, and I feel like the value of all of my data should be maximized to the greatest possible extent. Keeping all of that research data together would enable future N of 1 case studies that could provide clues to very targeted precision medicine. We may not know how things are connected now, but it might be helpful later. I know there's obstacles to doing that, like cost and logistics, time constraints, and interpretation issues, but I feel like there should be more of an effort to address and resolve those. I like the idea of combining individual secure central repository for collaborative future research as long as participants consent. I think it would ultimately save money and resources. For instance, I've had whole genome sequencing done multiple times before for research. So why repeat those redundant tests as long as it's from a approved source? I know there's been recent efforts to consolidate the data in the research infrastructure, but the participant still does not have access to it. However, I might notice an individual pattern that's not obvious to researchers when they're looking at the whole. My personal observations could spark novel avenues to pursue. In my opinion, I don't think the return of information back to research participants is given enough consideration in the current landscape of research study protocols, and I think it's an important topic to take a moment to highlight. Returning both our individual and aggregate information to participants in studies is one way to help with recruitment and keep participants engaged in future studies. This slide shows some of the individual information returned to me in a few of the studies I've participated in. Shown here are images from my PET scans when I was 36 years old. It included dopamine, neuroinflammation, serotonin, and acetylcholine. I also received results back from my smart pill and esophageal manometry tests. And for those of you that have never had an esophageal manometry, it's really not a pleasant test. But I've had it done several times as part of a longitudinal gastrointestinal study. One time that I visited, the manometry machine wasn't working. And to the surprise of the nurse, I was actually disappointed that I wouldn't be able to complete the test that day because I was very curious if my results would be replicated. Prior testing had showed that I had abnormal results. I have 90% failed peristalsis in my esophagus, and I would never have known that information without getting the results back from that research test. And now there's nothing that I can do to clinically treat it, but it's still very interesting and of value to me. And another example is this image of neuroinflammation in my brain using the PBR28 tracer. I laid still for about 4 hours in a PET scanner with both of my wrists throbbing from multiple attempts at intra-arterial lines, but I would absolutely do it again. That picture alone is fascinating and worth it to me. And this is individual results, something that's very rarely ever returned. But what is astonishing to me is that most studies don't give participants aggregate information back. But fortunately, I'm starting to gradually see that change. At a minimum, all participants should be given a copy of the final paper accompanied with an accompanying layperson summary. I'm encouraged, though, by recent efforts in the open access movement. Communication of results makes a big difference in our engagement. We deserve the reciprocity, and it has the potential to contribute to future individualized treatments. Throughout this talk, I've given you some insight into my grandfather's, my dad's, and my own research experiences through the lens of a LRRK2 carrier. But as many of you know, Parkinson's doesn't just impact the life of the person suffering with it. It truly has an impact on the entire family. As a granddaughter, a daughter, a wife, sister, and mother, I'm committed to doing everything I can to help both the current and the next generation. Family involvement and support definitely helps me to do that. My mom, my sister, and my husband have all participated as controls in Parkinson's research studies. Remember that you don't need to have a PD diagnosis to make a big impact. So just a few final thoughts. Like snowflakes, we're all unique individuals. None of us are exactly alike. Even among LRRK2 G2019S carriers, we can all still vary in our penetrance, our age of onset, progression, phenotype, and brain pathology. That is why I'm excited about the development of improved methods for precision medicine. And studying subtypes is just the beginning. Knowledge has a way of building, and there's plenty of overlap or discovery in one neurodegenerative disease or one genetic subtype will directly or indirectly benefit another group. But will take great collaboration and increased research participation to get there. As Michael J. Fox is quoted, the answer is in all of us. Thank you so much for listening to my personal story, and I'm hopeful that meetings such as these will bring context and progress to our collective efforts in PD research.